Hello friends, myself Dr. Atul Sarode. I am practicing since 25 years. I am practicing in Sauda, a small town of 16,000 population in Raver Taluka, Jalgaon district, Maharashtra. Friends, today I want to talk about SGLT2 inhibitors, whether it's a wonder drug or a blunder drug. So I am going to just put my views, and you also use your own conscious, use your own common sense, and think on what I'm trying to say. Friends, as of all you know that when we were in the medical colleges, that time what we learned was all basics. But thing is that in diabetes, in blood pressure and heart attack, there are many drugs coming almost every 5 months, 6 months. And we are blessed by the MRs and the pharma companies, because the MRs visiting our consulting, they are updating our knowledge about the newer modalities of treatment, the newer drugs, and that is in fact good for all of us. But sometimes I have seen that I feel that we are taken for granted. They bombard us with so much commercially manipulated data, and they hide some important facts, and so our own judgments and our own common sense is obliterated, or rather obliviated, by their constant hammering. This is what I have seen in last few years. Now, whenever we are treating diabetes, what we are exactly treating, what diabetes exactly is. You may say that we are all physicians and you are telling us the basics of diabetes treatment. But friends, let me just recapitulate some things. That what is the basic defect in diabetes, what we are treating, is that the glucose in the blood circulation fails to enter the cells for its metabolism, and that's why there is a hyperglycemia. Hyperglycemia is not a disease. The disease is the glucose in the circulation fails to enter the cells. That is the basic defect. Hyperglycemia is just the sequelae. So whenever we are treating, we don't concentrate on hyperglycemia. We facilitate the glucose to enter the cells. Now, why the glucose is not entering the cells is because of either there is a lack of optimum level of insulin, or there is an insulin resistance, or both. So whenever we are treating, our focus is to make the glucose available to the cells. That's our focus, and that's what we achieve by optimizing the levels of insulin, by giving either secretagogues or GLP-1 analogs, or incretin inhibitors, incretin breakage inhibitors, that's what we call as DPP4 inhibitors, that we give, or we give directly insulin. And if there is a resistance, then we are bound to give biguanides. We give usually metformin, which decreases the insulin resistance. So that's how we should treat diabetes. But what happens? See, hyperglycemia is never because patient is consuming extra glucose or patient is unable to excrete glucose. So patient is consuming fixed diet. So in that, whatever glucose is producing, his body is unable to use it. So any drug which reduces the absorption of glucose or increase the excretion of glucose has questionable place in treatment of diabetes. I think it's of no use. If we take like the drugs which reduce the absorption of glucose, for example, let us take alpha-1 glucosidase inhibitors like acarbose, voglibose, miglitol, all these drugs. See, patient hasn't consumed extra calories. Patient has consumed his regular diet. What patient eats is 2 or 3 rotis, 1 vegetable, 1 katuri dal, and little bit of rice. This is what is a normal diet. There may be variety in diet, but the daily calorie consumption of almost all patient is same. Patient hasn't consumed any extra calories. By giving the glucosidase inhibitors, what we are doing is we are stealing few calories from the patient's diet and making me obnoxiously flatulent. Because if the polysaccharides, they remain in the intestine, they are acted upon the gut flora and they produce flatulence. There are some companies which claim that our acarbose or our miglitol, voglibose, whatever it is, does not cause flatulence. Frankly speaking, they are giving just non-absorbable placebos. If it has to keep some polysac in the intestine, it will produce flatulence. This is for sure. So there, if say something like if there is a stachys, raffinose or vercabose, these are the polysacs which are in the intestine, definitely they will produce flatulence. So let me stick to the today's topic. Even these drugs are useless, that is one thing. But let me stick to today's study, SGLT2 inhibitor. What is SGLT2? See, there is sodium glucose transporter proteins. One is SGLT1, one is SGLT2. The function of this transporter protein is to transport the glucose across the membrane. First is SGLT1. This is present in the brush border of intestines, which helps to absorb the glucose, that is transporting glucose from the food to the blood in the intestines. Then second is SGLT2. It is present in the proximal nephron, the proximal tubule of nephron. It reabsorbs the glucose across the membrane, which is already filtered by the glomerular membrane. So that is the function of SGLT2 inhibitor. It will stop reabsorption of glucose. That's why the patient will have glycosuria or glucose diuresis and his blood sugar will come down. And you tell the patient proudly, see, I have brought down your sugar. But what about the cells in the body? Patient has not consumed extra glucose which we are pouncing on to milk it out through his urine. That is not our job. Patient has consumed fixed diet. Why you want to waste his diet? Whatever he has consumed. So if the sugar goes in the urine, patient develops a glycosuria and he develops all the complications of glycosuria, like he may have hyponatremia, he may have genital infections, he will have dehydration, all the complications in the diabetes which are because of hyperglycemia and glycosuria will be there because of your drug. So we should think 10 times before starting SGLT2 inhibitor to the patient. It never causes the entry of glucose in the cells. So basic defect we are overlooking. We are just trying to show the patient, it's just a pompous show that see, I have reduced your blood sugar. And patient is happy because patient is consuming something very costly. Because most of the useful drugs like all the sulfonylureas and metformin, they are gone in DPCO. They are cheaper. So just to satisfy the patient's query, you need not go beyond science or go against science rather, I'll say. So SGLT2 inhibitors that way is absolutely of no use. Now see, when we are reducing the sugar by glycosuria or glucose diuresis, we are simply failing the basics of treating diabetes. Now the companies claim that if you give SGLT2 inhibitors, it will cause weight loss. Now, how does it cause weight loss? You are stealing calories from the diet and you are causing dehydration. That's the reason why patient has a weight loss. Then secondly, they say that it reduces the cardiac workload. But that any diuretic will do. Any diuretic will reduce the workload. Even a pint of beer the patient consumes, that will also cause diuresis, that will also reduce the workload. But is that a thing which you will recommend? Never. See, I'll give you an example. If you have a motorcycle and the motorcycle is having a petrol overflow problem, what you will check? You will check the plug which causes the combustion of petrol, or you will check the carburetor. But if your motorcycle has a petrol overflow problem and you make a hole in the petrol tank and tell that, see, I have reduced the overflow, then you have the extraordinary intelligence. And the same thing you are doing by giving SGLT2 inhibitor to the patient. So my request to all of you is that please your own common sense. If you want to treat diabetes correctly, first open the book of physiology. First open the book of pathophysiology. What we are exactly treating. We have to just facilitate the glucose to enter the cell. By whatever mechanism we do, whatever drugs we give, we just achieve this thing. If we are giving insulin or insulin sensitizers or secretagogues, we are trying to make the insulin to the optimum level so that the glucose will enter the cell. This is the basic of treating diabetes. Hyperglycemia, we don't treat hyperglycemia. Hyperglycemia is a sequelae because of lack of entry of glucose in the cells. So we in turn make the glucose available to the cells. This is the treatment we do, and that is causing normoglycemia. So normoglycemia is a sequelae, not by hook or crook you reduce the sugar of the patient. That is never seen. So my request to you is, you please recheck the basics of your treatment of diabetes. Never fall prey to the commercial hammering of pharma companies, never or the MRs rather. So first use your own judgment, you use your own common sense. And if you want, see, this is what I wanted to tell you, that any drug which reduces the absorption of glucose or increases the excretion of glucose has no place in treatment of diabetes as far as science is concerned. Commercially and conference wise, these are all manipulated data. Now you may ask me that why did not I write a paper on this or present in a conference? See, SGLT2 inhibitors, drug like SGLT2 inhibitors, they have come to the market just because of these conferences and these sponsored lectures. So I don't want to explain myself to all these sold out souls and try to convince them, because they already know what is the science. They have some sponsored idea, that's all. So I don't want to criticize them. I don't want to criticize anybody. I just want all of us to be loyal to the patient's well-being, to the patient's pathophysiology, which we are trying to improve. So please give a second thought before using SGLT2 inhibitors. See what is it doing in the patient's body. I have seen so many patients who have put on SGLT2 inhibitors who presented to me. It was started by somebody else. They presented to me with severe hyponatremia. They were unable to walk. They had all giddiness, girdle muscle weakness, severe genital infections. All of them got well once their SGLT2 inhibitor was stopped. So again, I request you, whenever you're writing SGLT2 inhibitors or if somebody is promoting, always open a book of physiology, open a book of pathophysiology. If it fits in your mind, then you please go ahead, but give it a second thought. That's my request. Thank you.